Good afternoon, everyone. Thanks for joining me today to talk about VEDs and ICI efficacy. What should we really be telling patients? I'm Rafi Bole. So it's Friday afternoon. You have a new ED consult who walks in. Your patient's already tried PDE5 inhibitors, tells you definitively he's not interested in surgery. He wants to know what else you can offer. So you say, how about a vacuum device, or how about penile injections? But he's very apprehensive. He says, I heard that those don't work and that people stop using them over time. And he's not wrong. The dropout rate for both of these modalities is quite high. But why is that? So I decided to get some insight from patient reviews. So I thought this was going to be super easy. Went on consumerreports.com and I searched vacuum erection device. But imagine my disappointment when I saw no reviews. So unfortunately, that meant only one thing. I had to do my own review. So here goes. A brief history. In 1874, that was the first time that the penile vacuum device was first developed. And after a very long hiatus through which the device was thought to be too scandalous to ever be commercially successful, it was finally FDA approved for ED in 1982. And for a brief period, it was the most popular treatment modality for ED in the country. And then we discovered Viagra. So it can be used in ED. It's also used in post-prostatectomy rehabilitation without the use of the tension ring that I'll show you on the next slide. And it's often also used pre-prosthetic surgery to maximize lengthening. There are just a few patients in whom you want to use caution, those with limited manual dexterity who won't be able to release the tension ring, those with impaired sensation, and of course, anyone who's going to be using excess alcohol or drugs, you really don't want to fall asleep with that ring on. So the VED consists of a clear plastic vacuum cylinder and what is usually a battery-operated pump. That generates a negative pressure of a minimum of negative 100 to negative 150 millimeters mercury. That's going to expand the corporal sinusoids with a mixture of arterial and venous blood. And then there is an elastic tension ring at the penile base that traps the blood and keeps it in. The device, the tension ring usually also features easy grip tabs and a notch where the urethra is. And the average cost to tell patients for a medical grade device generally runs around $200 to $300. There is an optimal pressure to these devices that tends to be somewhere around negative 200 millimeters mercury, and all medical grade devices will have a pressure limiter and a quick release of the vacuum built in, because exceeding these limits can cause tissue damage. It's important to tell patients how to use these devices. So I tell patients to shave or trim pubic hair, that their effect may be enhanced by using PDE5 inhibitors along with the vacuum device to enhance their erection, to make sure that they use enough lubrication and to apply firm pressure to create a tight seal. And at first, at least just to practice without the tension ring. The tension ring actually requires a surprising amount of manual dexterity to get onto the cone, and so I do recommend using this loading cone. It's usually provided, but if it's not provided, I do recommend to patients that they purchase one. Troubleshooting, again, very important for these. It's one of the main reasons that people stop using them is because they can't get it to work. If men can't get or maintain an erection, it's important to check the vacuum seal, use the correct size ring, and even double up on rings if needed. For those who find that the scrotum is getting pulled into the device, check the ring size, angle the cylinder downwards while pumping, and wipe off any excess lubrication off of the scrotum. Some will complain that the penis hurts with pumping, and it's important to slow down the pump speed to mitigate that. And for those who complain of a hinging effect at the base, it helps to try and get a partial erection with medication at first, and then even to adjust position. Sometimes it helps to try the receptive partner on top and direct the penis. Good education and support are key for compliance with these devices. One study showed that after device training, 96% of patients reported success, and 100% of them would have recommended the device to a friend. So proponents of VEDs say that, well, 90% of people can get a penetration quality erection with one of these. And partner satisfaction is also equivalent. It's fast to use once you get the hang of it, 2 to 3 minutes on average, takes minimal accessories, and is quite cost effective. Critics of the VED will say, well, the long-term satisfaction really drops off About 40% of men, or up to 40% of men, will complain of a cool or a dusky-looking erection or petechiae, and up to 30% of men also will report difficulty with ejaculation. And of course, there is that learning curve. Moving on to a review of intracavernosal injections. Unfortunately, I was not able to purchase one without a prescription, but here goes. These are some of the very popular formulations that are available. Trimix is a common one, and that means that the vasoactive agents in there are typically papaverine, phentolamine, and prostaglandin E1. Now, you can prescribe PGE1 or alprostolol by itself to a patient. It is the only FDA-approved ingredient in that mixture. There are also patients who like to use bimix, and this is for patients who like intracavernosal injections but have some penile pain, usually coming from that prostaglandin E1. Quadmix is for patients who like using trimix but need a little extra strength, and that usually means the addition of atropine. And for those patients who are really, really just not ready to have surgery, there is always something called pentamix. And this is just a brief overview of some of those vasoactive agents. The ones towards the top will be the most common ones that we just mentioned, and you can add some other vasoactive agents as well for Scolin and VIP, but I will say that those are getting a little bit more boutique-y, and the options will often differ depending on the pharmacy and the pharmacist that you use. Injections can be used in ED or in penile rehabilitation. They should be avoided in anyone with a history of priapism and used with caution in those with Peyronie's disease. It's important to tell patients that frequency might be an issue for them depending on their goals. We generally recommend no more than 3 times per week with 24 hours in between. And cost may be an issue for some because this can vary by pharmacy and formulation. But in general, Trimix, which is one of the popular formulations, can run anywhere from $60 to $150 per vial. I do recommend multiple layers of education to patients when using these. There are multiple online teaching videos through various institutions that are very high quality that can help with this. An in-person teaching visit is also essential, and then I do always recommend to patients that they keep a home journal to help them with dose titration. Troubleshooting, again, very important in this modality. I tell patients it often works better standing. For those patients who have shaky hands, an auto-injector might help them, and this also helps those who are squeamish and don't like watching the needle go in. If the needle insertion itself is painful, those patients might try lidocaine cream or Emla cream. But if it's the medication itself that causes burning, like we were talking about before, bimix might be helpful, or even low alprostadol trimix is an option at some pharmacies. And I also always recommend purchasing some short-acting Sudafed in the event of a prolonged erection. Very importantly, don't forget to tell patients about storage. These medications need to be stored in a dark room in an airtight container. The dry powder can actually be kept at room temperature, but once that solution is reconstituted, it has to go in the fridge. Now, this is with the exception of bimix that doesn't contain alprostadol, which is the least stable component, so that one can be kept at room temperature. Otherwise, the solution is going to last for 1 month in the fridge or 6 months in the freezer with 1 thaw allowed. And for patients who like to travel, they should probably look into purchasing a refrigerated travel kit. Proponents of injections say that the injections are extremely effective across etiologies for ED with a very high partner rating as well, approaching 90%. They work fast, and for many patients whose goal is to try and avoid surgery, this can help them with that goal potentially, and it can be cost effective depending on the frequency of use. For critics of injections or those who don't prefer them, they cite the rate of potential for prolonged erection, for priapism. Up to 30% of patients might experience penile fibrosis, depending on the agent and duration of use. 30 to 40% might complain of penile pain or discomfort. There are low risk of hypotension as well with this, and of course, not a good option for those with needle phobia. So in summary, both VED and ICI can be effective therapies, but inadequate education and difficult logistics can limit satisfaction and compliance. But prescribing doesn't have to be hard. It's important to include brochures and websites, approximate pricing, and a teaching visit in person. And of course, always remember to follow up because patients may need to switch doses or realize that they're finally ready for alternate therapy. Thank you very much.